On behalf of AvicennaSociety, I appreciate this opportunity today to talk about the sacroiliac joint fusion. Sacroiliac joint fusion is very close to my heart because it has really transformed my own practice. But I need you to understand that we did in 1930s and 40s a lot of sacroiliac joint fusion because we knew it's a source of pain, but we more or less quit doing that because we got better with the lumbar fusion techniques, and sacroiliac joint was a very, very invasive procedure. When you have 100 patients in your practice for the first time for back pain, the statistic says 22% of that is not spine, but the sacroiliac joint. But it's important to understand that if you have 100 patients with previous fusion in your practice, 43% of them, then the problem now is the sacroiliac joint. Many of these patients, when we don't look at the sacroiliac joint, we miss the proper diagnostic and we declare them as failed back syndrome. The rate of failed back syndrome is a fraction of what it used to be in my practice since I have adopted sacroiliac joint in my differential diagnostic. Sacroiliac joint is a very complex joint. It's actually very strong, has very strong ligament, and as a matter of fact, the sacroiliac joint has very little physiologic motion. There's not a single muscle that acts directly only on the sacroiliac joint. And only time in human life it really moves is during the birthing process, open up the pelvis for the fetus to pass through. Now, most of the important nerves are anterior to the sacroiliac joint, and obviously we don't approach that joint anteriorly. Going posteriorly, there are some sensory nerves involved, and they are at the risk of approach from the posterior. And here is another schematic of the sacroiliac joint. So posterior approaches had been used previously to address problem of the sacroiliac joint. Now, the joint has a very interesting anatomy. It has two parts, what we call a ligamental region and articular region, or the boomerang. That is how it looked like. For everybody who has gone through orthopedic residency, you understand this in any other joint would be extremely pathologic joint, but that is a normal sacroiliac joint because it has no function. Nature allows a lot of variation. And as a matter of fact, what you see, the white part or yellow part is the articular part of the joint. We know this is a disease of more younger patients, mostly in their 30s and 40s, and mostly female are affected. And as well, even mild trauma and other trauma can contribute to that. Typically, this is a young female runner in childbearing age. Now, here is the distribution of the back pain, and as you see, there's a significant part that comes from the sacroiliac joint. But I want you to as well understand that still the majority of them are not sacroiliac joint. So this is only one part of the differential diagnosis. My personal experience is, as we discussed with you, that I have very little failed back syndrome compared to the time that I wasn't including it in my practice. And many authors and experts agree now sacroiliac joint is nothing but the adjacent ligament disease to L5S1. Now, there's a name we give to this joint. We call it chameleon joint because it can truly pretend to be facet, disc, even pelvic structure, even hip. And what as well I need you to understand is the imaging is not going to be diagnostic. The joint has so many variation. The CT or MRI, they are needed to rule out other pathologies, but they are not diagnostic by themselves. So what is diagnostic? Number one, you have to understand that having radiculopathy does not rule out sacroiliac joint disease. As a matter of fact, it is truly a chameleon joint. It can pretend to be radiculopathy in almost any segment in the lower extremity. Now, the diagnostic algorithm is mostly include that you include it in your differential diagnosis. And you obviously have to rule out the back problem, spine problem, because they are still the majority. And then positive provocation test, rule out other pathologies, and then at the end, sacroiliac joint blocks is the true diagnostic path to diagnose sacroiliac joint. This is a typical way patients describe their pain. They literally put their finger on the sacroiliac joint, which we have a name for. We call that 14 test. And they may have previous fall injury and so on, but you have to as well mostly be attentive if they had previous lumbar fusion. Now, I'm going to let you just read that, but this is can have many different presentation. And you have to just listen to the patient, examine them properly. And then obviously most important part is that you do provocation tests. These provocation tests start obviously with them putting the finger or the penis, and if they twice put the finger within 1 inch of the sacroiliac joint, that we call that 14 test. This test usually aim to provoke and stress the sacroiliac joint, and because it is ligamentally so strong, you have to really put some effort on that, and that is another reason why we are neglecting it. We are developing what we call a rapid provocation test, where practically patient sits on a chair, and you put the ankle on the knee, and then you do this with patients sitting. With some variation of that, you can practically do it a rapid test, and then let your assistant or physical therapy do the full test for you. But here, as you see, we are doing the Faber test and so-called distraction test, compression test, and then the thigh thrust and Genslin test that practically we are provoking the joint to see if we can provoke the pain. Many of these patients, they can tell you, you don't even need to do that. They say that any of those motion cause pain for them in a tremendous way. Now, conservative therapies, physical therapy, bracing is not really helpful. And as well, radiofrequency ablation is not very helpful because those nerves are very spread out. The gold standard of diagnostic is a sacroiliac injections. What's important is that you use a fluoroscopic guided or CT guided, use a low volume like 2 cc, and the result need to be more than 75% pain improvement, even for few hours, but realistically a day or two. The second injection is net for confirmation. It used to be 3 injection, but now most of insurances allow 2 injection. Here you see the reason why classical blocks, they are not very helpful. These are more spread out compared to the medial branch blocks, but it's still being done, but it's just not as successful as medial branch blocks. Practically, I can tell you nobody does open surgeries anymore. The number of the open surgeries are going down because they are very, very invasive. This is a landmark study where you see with the sacroiliac joint fusion, the pain drops and stays down. I can just tell you, if you look at the control level, after 6 months, it was unethical to continue that. They were all converted to the fusion, and they behaved like the people who got the treatment. So open techniques, nobody really recommends that as well. Medial to lateral is not very effective. The lateral to medial approaches has been tremendously successful. And all you need to know there is the superior gluteal artery might be, or one of your distributaries might be in your way. But the entry point is mostly superior and posterior to most of the important artery. Obviously, if you go approach it from lateral to medial, and what you need to know in the X-ray, you have to get a true lateral X-ray of the pelvis, meaning that the so-called greater sciatic notch and ala should be aligned as much as you can in a true lateral. Then this is one of those areas that there are two specialized X-rays are needed. This is so-called inlet view, where it's a true axial picture of the sacrum. Practically in this picture, you're aligning the ridges of the S1, S2, S3. You have to disregard S4 and S5, but you get a nice line here. And then the so-called inlet view, I'm sorry, that was inlet view. This is the outlet view, where it's a true AP view of the sacrum. Obviously, sacrum is not in the same plane as a normal AP view. So to get that, you have to bring your C-arm toward the head to get a true AP view of the sacroiliac joint. I have experienced lots of different devices. These are so-called SI bone, they plug. The company itself is now producing screws. So comparing screws to the plugs, I think I always prefer screws. And I tried different kind of screws, and obviously you have to put more than one screw to stabilize the sacroiliac joint because it still can rotate around one screw. So two or three screws are needed. And I prefer screws with the cavity inside because bone can grow through them and provide you with the actual fusion. And the screw can become part of the fusion. So here you see alignment of the greater sciatic notch and ala. And in our procedure where we go lateral to medial, we use a method that we go perpendicular to the sacroiliac joint. And that requires us actually to draw the shadow of the sacrum on the skin, as you see here. Then we go from the promontorium, which is the posterior, superior part of the sacrum, to the middle of the sciatic notch. And the middle of the sciatic notch is where we enter the skin. Then, as you see here, once we enter the skin, our entry to the iliac bone is just anterior to the sacrum or shadow of the sacrum because it has to traverse the iliac crest before it centers on the sacroiliac joint. Now, here you see the so-called inlet view and what to look for. Here you see the outlet view and what to look for. But more or less, you have to put multiple screws to stabilize the joint. Now, the screws can be solid screws. I prefer hollow screws that allows the bone grow through them. And now these days, I'm using this device. We call that Trident, where practically you poke the patient only once. The second and the third screw go through the screwdriver of the first screw, so you don't have to do 3 pokes. That makes the surgery extremely efficient. Practically, these surgeries are less than 20 minutes, and patients are discharged within an hour after the surgery. And many of these patients, we don't even do a general anesthesia. We do just like some sedation and MAC. Here is another picture of Trident in the inlet and outlet view. And I thank you so much for the opportunity. Please join our society. And if you have any questions, just connect to me. I'm happy to answer them all for you. Thank you very much.